Okay, so for today's deep dive, we are jumping right into the chemistry of calm.
Yes, the world of sedative-hypnotics.
Exactly. These are the drugs that, they fundamentally modulate our central nervous system, our entire state of being, really,
Could you?
to either induce a state of calm or, well, outright sleep. It's a journey that takes us from ancient opium all the way to these incredibly modern brain-specific keys.
And that's really the core of our mission today. We're working from a whole stack of pretty detailed pharmacology chapters to define these compounds.
Right.
But more importantly, I think, to understand the huge shift in molecular strategy that's happened over the last century.
It's not just about making better drugs, it's a completely different philosophy.
It is. It's a transition from using, an indiscriminate sledgehammer on the brain to using a highly specialized molecular key.
So let's unpack the basic vocabulary right at the top. We tend to toss around sedative and hypnotic almost interchangeably in conversation.
We do.
But pharmacologically, they describe two very distinct, even if they're overlapping, effects. So what's the clear line between them?
The distinction really comes down to dose and
Yeah.
and the desired outcome for you, the patient.
Okay.
A sedative is an agent that's designed to subdue excitement and calm the subject down. Its whole function is to reduce responsiveness to stimulation.
So it's like turning down the volume on everything.
Exactly. Turning down the volume on your anxiety, on motor activity. It might make you drowsy, sure, but it won't necessarily push you over that threshold into actual sleep.
And a hypnotic is when you're specifically aiming for that threshold.
A hypnotic is the agent specifically intended to induce and, just as importantly, maintain sleep.
Right. Maintaining it is key.
The goal is a state that closely mimics normal physiological sleep. And just to be super clear, we're talking about pharmacology here.
Not hypnosis.
Not hypnosis.
Yeah,
The trance-like suggestible state, totally different thing.
That makes sense. And the crucial insight, which I think we'll keep coming back to, is that they're really 2 points on the same continuum, aren't they?
Precisely. They're both general CNS depressants. It is a dose-dependent effect.
So a little bit of a hypnotic is a sedative.
A hypnotic at a lower dose can absolutely act as a sedative. And if you take an even higher dose of either, you enter a state of general anesthesia.
So the difference is often in the design, the kinetics of the drug.
Yeah, drugs with a quicker onset and a steeper dose-response curve are usually preferred as hypnotics. They're designed to get you to sleep quickly.
Okay, before we dive into the deep chemistry, let's get some historical context. Because when you look at the timeline of what people have used for calm, it's a story of desperation and, frankly, a lot of accidental discovery until pretty recently.
Oh, for millennia, humanity relied on alcohol and opium. Potent, for sure, but inherently uncontrollable depressants.
And dangerous.
Incredibly dangerous. The first true synthetic agents didn't show up until the late 19th century. You had chloral hydrate in 1869, then pearaldehyde in 1882.
These were the first attempts to make something chemically reproducible, right?
They were.
Yeah.
But they still carried just enormous risks.
And then came the real game changer of the early 20th century, the drug class that really defined calm for, 50 years? The barbiturates.
Absolutely. Phenobarbital arrived in 1912, and with it, the age of the barbiturates. They reigned supreme in sedation and sleep all the way until the 1960s.
This was the era of the sleeping pill culture that we see in old movies.
It was, and it often had just devastating consequences because of the inherent danger of the drugs themselves.
Which brings us to their replacement, the benzodiazepines, the BZDs.
And their arrival just fundamentally changed the safety profile for treating anxiety and sleep. They offered such a superior therapeutic window.
Meaning the gap between a helpful dose and a harmful one.
A much, much wider gap. They so quickly replaced barbiturates. It's not even a contest. It was a massive medical shift driven purely by chemistry.
But the evolution didn't stop there. Now we seem to be in an era of hyper-specialization, moving beyond even the versatile BZDs to drugs designed to do just one job, but do it extremely well.
That's the cutting edge. We now have non-BZDs, the so-called Z drugs like zolpidem or zaloplam,
Right.
and even totally novel mechanisms that bypass that traditional inhibitory system entirely. Things like remoltown, which is a melatonin receptor agonist, or suvorexant, an orexin receptor antagonist.
So the whole trajectory is clear. Less general brain depression.
And more precise modulation of the specific cycles of sleep and wakefulness.
Okay, let's unpack this then. To really appreciate how, as you put it, barbiturates smashed the brain and how BZDs tried to fix that damage, we have to first understand the target.
The Garga, yeah.
This delicate, incredibly elaborate architectural cycle that these drugs are messing with. We can't just talk about being unconscious. We have to talk about inducing functional, restorative sleep.
And that architectural cycle is absolutely key. Sleep isn't linear. It's not just an on-off switch.
It's a process.
It's a repeating process. Over about 80 to 100 minutes, the brain cycles through these different electrical states. We call them stages 1 through 4, which then culminates in REM sleep.
And then it just starts over.
And then it repeats, usually 4 to 6 times a night. This whole pattern is fundamental to getting restorative rest, but it does vary a lot based on age and, individual genetics.
So walk us through those stages. Let's start from the moment we actually begin to drift off.
Okay, so we begin with a very brief period. The sources call it stage 0, awake drowsy.
Stage 0, so you're not even really asleep.
Not quite. Your eyes are usually closed, and that high-frequency beta activity of the awake brain starts to decrease. Meanwhile, the alpha waves, the relaxation waves, begin to increase.
And this is just a tiny fraction of the night.
Tiny. It only accounts for about 1 to 2% of total sleep time. That includes those little brief awakenings we all have during the night.
Then you slip into stage I, dozing. This is that limbo state, where you might not even be sure if you were asleep or not if someone woke you up.
That's it, exactly. It's where your eye movements slow down and become sort of rolling. Activity is reduced, but you are very easily startled.
An introductory phase.
Right, making up only about 3 to 6% of the cycle. But the moment you enter stage 2, unequivocal sleep, you are truly under.
And stage 2 is the big one. This is where we spend most of the night, right? 40 to 50%.
It is the lion's share of our rest.
So what defines this stage in terms of brain activity? What would we see on an EEG?
This is really the maintenance phase of sleep. On an EEG, we see theta waves and then these highly characteristic patterns called sleep spindles and K complexes.
Spindles and K complexes.
Spindles are these short bursts of rhythmic brain activity, and K complexes are these big, high-amplitude waves that often happen spontaneously or maybe in response to a small noise.
So stage 2 is where we're spending most of our time. It's stable sleep, but we can still be woken up if needed.
Exactly. But the really deep, restorative, sort of metabolic cleanup work that happens in the next 2 stages, stage 3 and stage 4.
Which together are known as slow wave sleep, SWS.
That's right.
This is the deep sleep, the one everyone feels like they're not getting enough of.
It is. Here, very slow, high-amplitude delta activity just dominates the EEG. The eyes are practically fixed. Subjects are incredibly difficult to arouse.
And the body is resting, too.
Completely. Heart rate, blood pressure, respiration, they're all significantly reduced and nice and steady. Stages 3 and 4 together make up about 20% of our sleep time.
And this is where physical recovery happens.
Peak physical recovery. Growth hormone release is at its highest here.
So you go down into this deep, slow wave state. But then the brain cycles back up into this absolute anomaly of the sleep world, REM sleep.
REM, rapid eye movement, or as it's sometimes called, paradoxical sleep.
Why paradoxical?
It's paradoxical because the brain's electrical activity looks almost identical to the awake state. It's dominated by low-amplitude, high-frequency waves. And yet,
your body is paralyzed.
Your body experiences profound muscle atonia, a functional paralysis.
Which is the body's clever way of keeping us from acting out our dreams.
Precisely. Because dreams and nightmares are happening during this time. We spend about 20 to 30% of our total sleep time here.
And REM is critical for the mind.
Absolutely crucial. For cognitive function, emotional regulation, memory consolidation, disrupting this stage is where those old hypnotics cause the most amount of trouble.
Let's quickly put those brain waves into context just to complete the picture. If you're listening and you're awake, stressed, actively concentrating, your brain is running on beta waves.
Fast, above 15 cycles per second, and low amplitude.
But then you close your eyes and relax, and the frequency slows down a bit, and the amplitude gets bigger, and that gives you alpha waves.
Right, 8 to 14 cycles per second. That's the brain's engine just idling down.
And as we move into sleep, things slow dramatically to theta waves in light sleep.
4 to 7 cycles per second. And then those really slow, deep, high-amplitude delta waves, 0.5 to 3 CPS, they characterize slow wave sleep.
So it's that intricate balance, the cycling between all these waves, that a good hypnotic drug aims to preserve.
And a bad one completely, utterly destroys.
Which brings us to the core mechanism.
Yes. This is where we have to get into the chemistry of control. If all these different chemicals, from barbiturates to benzodiazepines to the Z drugs, are all acting to depress the central nervous system, they have to share some kind of common molecular target.
And that target is GABA, gamma-aminobutyric acid.
GABA.
If glutamate is the main accelerator of the CNS, GABA is the absolute #1 primary brake.
It governs the vast majority of inhibitory action in the brain.
So the goal of all these drugs is just to help the brake work better.
Exactly. The primary goal is to facilitate the action of GABA. Now, GABA binds to the GABA-A receptor, which is structurally a very complex protein that spans the cell membrane. Fundamentally, it's a channel.
A channel that lets chloride ions through.
A chloride ion channel. So let's use that analogy we talked about. Think of the whole GABA-A receptor complex as a highly specialized door lock on the surface of a neuron.
Okay, a door lock.
In that analogy, GABA itself is the key. When the key, GABA, binds to the receptor, the chloride channel opens.
And chloride ions are negatively charged.
They are. So when they flood into the neuron, they make the inside of the cell highly negative or hyperpolarized.
And if a cell is hyperpolarized, it's much, much harder for an excitatory signal to make it fire.
It's inhibited. It's calmed down.
That's the brake pedal at the molecular level.
Which translates systemically to sedation and sleep. Now, here is where the massive fundamental difference between barbiturates and benzodiazepines emerges.
They're both helpers, but they interact with that lock in wildly different ways.
Wildly different.
Okay, let's start with the benzodiazepines, the BZDs. The precision tool. Where do they bind on that lock?
BZDs do not bind where GABA binds. They latch onto a completely separate site on the receptor. It's called an allosteric site, located specifically between the alpha and the gamma subunits.
And what do they actually do to the function of that door lock once they're bound?
They're frequency modulators.
Frequency modulators?
So think of BZDs as a shot of WD-40 applied to the lock.
Ah, okay.
They don't turn the key themselves. They don't hold the door open. They simply make it easier for the real key GABA to turn the lock. And so they increase the frequency of the channel opening.
So a BZD needs GABA to be there to do anything if there's no natural inhibitory signal.
The BZD can't open the door on its own. Precisely. They only facilitate.
And that one fact is why they're so much safer.
That is the critical distinction. Their action requires the natural brake pedal, GABA, to be engaged. And this places a natural functional ceiling on how much inhibition they can cause. They can't just keep hyperpolarizing the neuron forever.
Now let's contrast that with the barbiturates, the old sledgehammer approach you mentioned. They also bind to a different site.
A different site, yes.
But the molecular consequence is fundamentally more dangerous.
Barbiturates bind to yet another distinct site on the receptor, and what they do is prolong the duration of the chloride channel opening.
Okay, so they're not increasing the frequency.
They're holding that door open for a much longer period of time once GABA has bound and started the process.
So to use your analogy, BZDs make the brake tap more often, and barbiturates hold the brake pedal down to the floor for longer.
That is a perfect summary of their facilitatory action.
Yeah.
But here is the mechanism that defines the lethal toxicity of barbiturates.
There's more.
At high concentrations, they become GABA mimetic.
Meaning they mimic GABA?
They can open the chloride channel directly, even when GABA is completely absent.
Whoa. So they bypass the natural key entirely. They're like a chemical crowbar that just forces the channel open.
Exactly. And because they can mimic GABA and open the channel directly, there is no physiological ceiling to the CNS depression they can cause.
So it's a runaway train.
If the concentration is high enough, they will flood the neuron with chloride ions until that neuron and ultimately your entire respiratory system shuts down. That is the root of their greater toxicity, and that is why they were replaced.
Here's where it gets really, really interesting then. Once you understand that lethal mechanism, that GABA mimetic action, you totally get why barbiturates were phased out. The risk-to-benefit ratio was just astronomical.
It was a necessary transition. It had to happen. A barbiturate's depressant effects are strictly dose-dependent and linear. Sedation moves to sleep, then to surgical anesthesia, then to coma, and eventually death. And the margin between a therapeutic dose for sleep and a lethal dose is it's frighteningly narrow.
And the problem wasn't just acute overdose. It was the chronic poor quality sleep they produce because they fundamentally screw up the brain's natural cycle.
That's a major failing of the class.
Yeah.
Hypnotic doses of barbiturates significantly depress those deep restorative stages we talked about, stage 3 and stage 4 slow wave sleep.
The most important ones for physical repair.
Exactly. But their most notorious crime against sleep architecture is the severe suppression of REM sleep. especially if you use them nightly for several consecutive nights.
The brain needs that REM sleep. So if you artificially suppress it for a week, what happens when you stop taking the drug?
You experience a massive REM rebound effect.
A rebound.
The brain tries to catch up very rapidly on all the lost REM time. This leads to a disproportionately high percentage of REM sleep on subsequent nights.
Which sounds good, but it's not.
It's not. This rebound is associated with severely disturbed sleep, agitation, vivid and often terrifying nightmares, and just overall poor subjective sleep quality, even though the person is technically sleeping.
And that rebound effect, combined with their pharmacokinetic profile, just created a perfect storm for dependency. Let's talk about how quickly they get into the brain.
They are highly lipid soluble, which means they're quickly absorbed from the gut, and they cross the blood-brain barrier very, very rapidly.
And we categorize them by how long they last.
Right. We have long-acting agents like phenobarbital, which is used mostly for epilepsy now because of its sustained action.
And then the other extreme.
The ultra-short-acting ones, like ziopentone. These are so lipid-soluble, they just rush into the brain almost immediately, but then they rapidly redistribute out into peripheral tissues like fat.
So thiopentone is used almost exclusively in anesthesia because its action is over in, what, 5 to 10 minutes?
Exactly. Its action terminates because of that quick redistribution, not because it's been metabolized. It's an example of extreme chemical speed.
But all that versatility and kinetics, it doesn't mask their fatal flaw, which is rooted in tolerance and toxicity.
Tolerance develops very rapidly, and it's driven by two different mechanisms. First, you have cellular tolerance, where the CNS itself just adapts and becomes less sensitive to the drug's effect.
So your brain gets used to it. And the second mechanism is in the liver.
Yes, pharmacokinetic tolerance through what's called hepatic enzyme induction. Barbiturates are potent inducers of several CYP isoenzymes in the liver.
Meaning they tell the liver to make more of the enzymes that break the drug down?
Precisely. So your liver starts metabolizing and clearing the drug faster and faster over time.
So if you're the listener, you would need an ever-increasing dose to get the same initial hypnotic effect.
Because your body is basically chewing the drug up and spitting it out faster than before.
Right. But here is the devastating twist. The reason barbiturates were so lethal.
That tolerance does not significantly increase the lethal dose.
Wow. Okay, so the therapeutic window, that safe space between sleep and death, it doesn't expand even as the dose you need for sleep keeps going up.
Think of it like a fixed lethal cliff edge. The dose required for sleep creeps closer and closer and closer to that cliff as your tolerance builds. A patient trying to get the same effect they got a month ago might unknowingly step right over that fixed low threshold for toxicity.
That is terrifying.
This narrow therapeutic index, which is completely unchanged by tolerance, is the primary driver of fatal acute poisoning.
And that poisoning is, I imagine, pretty grim.
Highly morbid. Acute barbiturate poisoning is characterized by that excessive, runaway CNS depression. It leads very swiftly to respiratory failure. That's the GABA-mimetic action we talked about.
And that's not all.
No, it's compounded by cardiovascular collapse, severe pulmonary complications, all resulting in this deep, flabby, comatose state.
And finally, their widespread interaction with other drugs must have just caused absolute chaos in patients taking multiple medications.
Total chaos. Because they induce so many of those CYP isoenzymes, they accelerate the metabolism of countless other compounds. They significantly reduce the effectiveness of blood thinners like warfarin, hormonal drugs like steroids, even antibiotics and antifungals. This drug interaction profile alone makes them incredibly complex and dangerous to manage.
And when you add in other depressants,
when combined with alcohol, opioids, or even just over-the-counter antihistamines, the additive depression is profound and a major, major acute risk.
So if we connect this back to the bigger picture, the introduction of benzodiazepines in the 1960s, this wasn't just an improvement. This was a revolution in patient safety.
It was. The BZDs, just by virtue of their mechanism, fundamentally changed the therapeutic game.
It all comes back to that WD-40 action we talked about, increasing the frequency of the channel opening, but, and this is the key, requiring GABA to be present.
Exactly. And that mechanism is the foundation of their high therapeutic index. The difference is just staggering.
How staggering.
While a slight overdose of a barbiturate could easily trigger respiratory failure, the sources say ingestion of even 20 hypnotic doses of a BZD does not usually endanger life.
20 doses.
It will often result in deep drowsiness or amnesia, for sure. But respiration is typically maintained because they cannot fully override the system.
That's the mechanism-based safety ceiling in action. They just physically cannot push the CNS into full, unrecoverable shutdown the way barbiturates can.
Correct. BZDs are often categorized as selective CNS depressants because, unlike the general blanket depression caused by barbiturates, they show this incredible versatility across multiple targets.
So they do more than just sedate.
They relieve anxiety, they facilitate sleep, they act as anticonvulsants, and they reduce muscle tone, all from the same basic mechanism.
So how do they handle the delicate balance of sleep architecture compared to barbiturates?
Much better, but still not perfectly.
Okay.
BZDs hasten sleep onset,
Right.
and they reduce those intermittent awakenings primarily by increasing the amount of stage 2 sleep.
The maintenance phase.
Right. And crucially, they cause less profound REM suppression than barbiturates. And consequently, the rebound phenomena when you stop them are much, much less severe.
So they increase total sleep time.
But often at the expense of reducing stage 4, the deep, slow-wave sleep. So while they offer much safer quantity of sleep, they might slightly reduce the deepest, most restorative quality.
And that versatility is what made them such a dominant class. Beyond sleep, they are just essential in managing several critical conditions.
Most famously, they are key anxiolytics. Drugs like diazepam, lorazepam, alprazolam, they have a relatively selective anti-anxiety action.
And in emergency medicine?
Vital. As powerful anticonvulsants, agents like diazepam and lorazepam are the frontline treatment for things like status epilepticus, those severe continuous seizures.
And their use in surgery is fascinating.
They are essential as pre-anesthetic medications. Diazepam, when it's given intravenously, is extremely useful because it induces a significant degree of anterograde amnesia.
Meaning you don't form memories for events after you've taken the drug?
Exactly. The patient will not form memories of the surgical or medical procedure, and that is a massive clinical advantage, especially in unpleasant or stressful procedures.
Okay, this high therapeutic index and versatility sounds amazing, but BZDs are not all the same. The clinical relevance of half-life is huge here. Their duration can vary by, what, more than 50-fold?
The half-life and the metabolism determine everything about how you, the listener, would experience the drug.
So a fast-acting one versus a slow one.
Highly lipid-soluble agents like diazepam are absorbed very rapidly, so you get a quick onset. But the real complexity is in how the liver metabolizes them, mainly through CYP3A4 and 2C19. And many BZDs produce active metabolites that continue to work long after the parent drug is gone.
Ah, so the effect lingers. Let's break down that diversity, because it really dictates the clinical scenario. Let's start with the ones that stick around the longest.
Okay, the long-acting agents. These are drugs like flurazepam and diazepam. They have half-lives that can extend up to 100 hours.
100 hours.
Because they're active metabolites, like dismethyldiazepam, they accumulate. This ensures a prolonged action.
So these would be good for chronic anxiety or maybe insomnia where you're waking up all night?
They are. But the trade-off is a high likelihood of residual effects, a hangover the next day. That accumulation needs very careful monitoring.
Okay, what about the middle ground? The drug is designed to cover the night but clear out by morning.
These are the short-acting or intermediate agents, things like temazepam, alprazolam, and lorazepam. Their half-lives are typically in the 8 to 12-hour range.
Or manageable.
Much. Temazepam is a very popular hypnotic because it's metabolized directly to inactive compounds, so it minimizes those next-day effects.
So these are great for people who have trouble falling asleep or staying asleep, but need to be sharp the next morning.
Exactly. And finally, you have the ultra-short-acting agent, which has to be used with extreme caution. Triazolam.
Triazolam.
That's the ultra-short example. Very fast peak and a half-life of only 1.5 to 5 hours.
So it's in and out very quickly.
Which makes it highly effective for sleep-onset insomnia. But its rapid clearance creates major issues.
Like what?
If you use it repeatedly and then stop abruptly, that rapid drop in the drug level can precipitate severe rebound insomnia and anxiety.
So your sleep gets even worse than it was before you started.
Potentially much worse. And it's sometimes accompanied by a high incidence of that anterograde amnesia while the drug is active.
Even with this massive safety improvement, we can't just gloss over the adverse effects. What are the common downsides of BZDs?
Well, the common acute effects include drowsiness, dizziness, and, critically, ataxia.
Ataxia being impairment of physical coordination.
Yes, which means driving or operating heavy machinery is absolutely forbidden. The amnesia we mentioned is also a key side effect, an impairment in the ability to form new memories.
And what about the more bizarre side effects, the paradoxical reactions?
Yes. In some patient populations, particularly psychiatric patients, BZDs can paradoxically cause stimulation, irritability, sweating, restlessness instead of calm.
The exact opposite of what you want.
The exact opposite. Furthermore, long-term use of agents like nitrazepam or fluoxetine has been linked to increased nightmares and other behavioral changes, and they can worsen pre-existing sleep apnea.
And then the big one, the problem that still plagues this class today, dependence.
The high liability for both physical and psychological dependence is the BZD's greatest flaw.
So tolerance still develops.
Tolerance to the sedative effects develops gradually, yes. But the critical difference from barbiturates is that there's little tendency to increase the dose to dangerous, life-threatening levels.
But the withdrawal can be awful.
The withdrawal symptoms can be debilitating. Extreme restlessness, malaise, anxiety, agitation, tremors, delirium, and in very severe cases, convulsions.
And the withdrawal is worse with the faster drugs.
It's often more intense and more rapid with the ultra-rapid elimination drugs like triazolam. The system just gets a much bigger shock when the drug disappears so quickly.
So what does this all mean? BZDs were great, they were safer, they were versatile, but the medical community looked at those side effects, the muscle relaxation, the anticonvulsant effects, the memory impairment, and they started asking a question.
A very important question.
Can we make a drug that targets only the sleep component? Can we strip out everything else? And this brings us to the next generation, the specialists.
And this push for ultra-specificity is the modern goal. It relies on a much finer understanding of the GABA-O receptor. Remember how we said that complex has different subunits?
Right, alpha, gamma.
Well, the non-benzodiazepine hypnotics, the Z drugs, are chemically distinct from BZDs, but they act as agonists at the BZD site, with one crucial difference. They show relative selectivity for the alpha-1 alpha dollar subunit.
Okay, so why is targeting just alpha-1 so important for sleep?
The current consensus is that the alpha-1 subunit is primarily responsible for the sedative and hypnotic effects of this whole class of drugs.
And the other effects like anxiety relief and muscle relaxation.
Those are often mediated by other subunits like alpha-2 and alpha-3. So by selectively hitting just alpha-1, the Z drugs primarily produce hypnotic effects while having significantly lower anti-anxiety, muscle relaxant, and anticonvulsant activity.
It's a surgical strike for sleep.
That's a perfect way to describe it.
And they generally have minimal negative effects on the overall architecture of sleep, which makes them a preferred first-line treatment for insomnia over the traditional BZDs.
That's right.
Let's look at the three biggest names in this group, starting with zolpidem.
Okay, zolpidem. It has a quick onset and a short half-life, around 2 hours. This is excellent for short-term insomnia treatment, say 1 to 2 weeks, and it significantly minimizes any next-day impairment.
Because it's gone by morning.
Exactly. Its highly selective action on that alpha-1 subunit means it avoids a lot of the residual grogginess you'd get with older BZDs. And even in large doses, it typically doesn't cause significant respiratory depression.
Then you have zaleplon, which is even faster acting.
Zaleplon is incredibly short-acting. It has a half-life of only about 1 hour.
1 hour.
Because it's so rapidly absorbed and metabolized, it's specifically suited for sleep-onset insomnia difficulty falling asleep.
But it has a very specific niche use, too.
It does. Its true niche is for patients who wake up in the middle of the night. Let's say it's 2 a.m. And they need help falling back asleep. But they still have to be up and functional by 6 a.m. Because it clears so fast, it minimizes any morning sedation risks.
And then there's ezopiclone, which seems designed to bridge that short-term gap, maybe for more chronic use.
Ezopiclone. It's the active S-enantiomer of zopiclone. And it has a longer half-life, around 6 hours. It also acts on the alpha-1 subunit.
So it lasts most of the night.
Right. Its longer duration makes it suitable for both short-term and chronic insomnia treatment. It increases total sleep time, mainly by prolonging stage 2 without major disruptive effects on slow-wave sleep or REM.
But the evolution didn't stop at just improving the GABA system. We are now seeing drugs that entirely ignore that traditional inhibitory system and instead target the body's natural wakefulness signals. This is a complete conceptual pivot.
This is truly exciting. Instead of applying the brakes harder, which is what GABA drugs do, we are now modulating the accelerator.
Turning down the wake-up signal.
Exactly. First, we have Ramelteon, which is a melatonin receptor agonist.
Melatonin being the hormone that signals darkness and synchronizes our internal clock.
Correct. So Ramelteon acts on the MT1 and MP2 melatonin receptors. And crucially, it does not touch GABAergic neurotransmission at all.
It's a totally different system.
It simply reinforces the natural physiological signal to fall asleep, which hastens sleep onset. And the enormous clinical benefit here is that there's absolutely no evidence of dependence, withdrawal, or abuse liability.
Because it bypasses the traditional addiction pathways.
Completely.
And then we have the most radical shift of all, attacking the state of wakefulness itself using orexin receptor antagonists.
This is the newest paradigm. Orexin, which is also known as hypocretin, is a neuropeptide found mainly in the hypothalamus. And its job is to promote wakefulness and maintain alertness.
So orexin levels are high during the day when we're awake and low at night.
Naturally, yes.
So suvorexant, which is a dual orexin receptor antagonist, a DORA, it just blocks the signal to stay awake.
That is the elegant simplicity of the mechanism. Suvorexant blocks both the OXR1 and OXR2 subtypes of the orexin receptors. So instead of depressing your brain globally to force sleep,
You just turn down the volume of the central drive to remain conscious.
exactly.
Yeah.
This novel approach helps hasten sleep onset and maintenance. And early observations suggest that, in the doses studied, it doesn't reduce subjective alertness or prolong reaction time the next day, which is a massive advantage over older CNS depressants.
Okay, the final critical piece of this deep dive is how to apply all this knowledge clinically.
Right.
The challenge is matching a drug-specific pharmacology, its onset, its half-life, its side effect profile, to the precise type of insomnia you, the listener, might be experiencing, all while rigorously managing the risks.
It's not a one-size-fits-all problem.
The sources outline 3 main categories of insomnia based on duration, and the treatment approach is dramatically different for each. Let's start with the temporary kind of disruption.
Okay, transient insomnia. This is sleep disturbance lasting 1 to 3 days.
So jet lag, shift work.
Exactly. Acute stress, moving to a new environment. For these situations, rapidly eliminated hypnotics are the clear choice. We want fast onset and fast clearance.
Get in, do the job, get out.
Precisely. The Z drugs, zolpidem and zaleplon, are highly popular here because of that rapid action and minimal next-day impairment. It allows a person to reset their rhythm without that lingering sedation.
Next up is short-term insomnia. This lasts between 3 and 21 days. Maybe related to a bereavement, a temporary illness, or some severe but short-term work stress.
Here, hypnotics should be used, but very cautiously. Usually limited to low doses for 2 to 3 weeks, and ideally using an intermittent dosing schedule, not every single night.
And you want to avoid the long-acting ones.
You must avoid BZDs that have long-acting metabolites because they will accumulate and cause daytime impairment. The selection really depends on the underlying symptom, if anxiety is a primary feature.
Then a short-acting BZD might make sense.
A short-acting BZD like temazepam, which also offers anxiolysis, might be considered, but only if the duration is strictly limited.
And then we have the most complex category, chronic insomnia, lasting longer than 3 weeks. This can't be just a simple drug problem.
Absolutely not. For chronic insomnia, hypnotics are generally not a long-term solution. The uncertainty about their long-term value is significant because you have to address the cause first.
You have to find out why the person isn't sleeping.
You must look for underlying conditions: depression, an anxiety disorder, restless leg syndrome, or critical issues like undiagnosed sleep apnea or GED.
And the first line of treatment isn't a pill.
The mandatory first line of action is non-drug measures, like cognitive behavioral therapy for insomnia or CBTI. If a drug is used, it should ideally be one with low dependence risk, like Ramelteon or suvorexant, and used alongside treatment for the root cause.
Now let's pivot back to that crucial safety concern, synergistic interactions. We mentioned it with barbiturates, but it's still critical with BZDs.
The risk of synergy is immense. BZDs strongly amplify the effects of alcohol and other CNS depressants, including opioids, older antihistamines, and some psychiatric medications.
Leading to excessive impairment that can be fatal.
It can be. Furthermore, other drugs that inhibit those CYP isoenzymes, like certain antibiotics or antifungals, can slow the metabolism of BZDs,
So the drug builds up in your system.
drastically increasing its plasma concentration and prolonging its half-life, which increases the risk of severe adverse events and next-day impairment.
If an overdose does occur, management is primarily supportive, maintaining airway, respiration, circulation, But BZDs have a unique emergency tool that the older drugs lacked, a dedicated reversal agent.
They do. That is flumazenil. It's a competitive BZD antagonist analog.
An antagonist, so it blocks the receptor.
Think of it as a chemical key that fits the BZD receptor lock perfectly, but simply jams the mechanism. It blocks the action of the BZD agonists and reverses sedation and amnesia very rapidly, often within 1 to 2 minutes after an IV administration.
It's a true lifesaver in a controlled setting.
Yes, for reversing BZD effects during procedures like endoscopy or for general anesthesia recovery.
However, the sources stress a major caution with flumazenil. It's a double-edged sword, isn't it? Especially in certain patient populations.
It is a very high-stakes decision. If you administer flumazenil to a BZD-dependent subject, that rapid reversal will instantly precipitate severe withdrawal.
Which can manifest as what?
Agitation and grand mal seizures. Furthermore, you have to use it very cautiously in cases of mixed poisoning, particularly involving tricyclic antidepressants.
Why is that?
Because the rapid reversal of the BZD's protective anticonvulsant effect can unmask the cardiotoxicity and seizure risk of the antidepressant that was also taken.
And it's only useful for BZDs, not the whole class of depressants.
That is an absolutely critical point. Flumazenil is specific to the BZD receptor site. It is utterly ineffective against the non-BZDs like zolpidem or zaloplam.
And totally useless for barbiturates or alcohol.
Completely useless.
So in an emergency room, if patient comes in after a suspected polydrug overdose, giving them flumazenil might only partially reverse the sedation, if a BZD was involved, while simultaneously triggering a life-threatening seizure if they happen to be chronically dependent on a benzodiazepine.
It requires intense clinical judgment. The clinical benefit of reversing an acute BZD overdose must always be weighed against the risk of precipitating serious withdrawal in a dependent individual, or inadvertently complicating a mixed poisoning scenario. It is a powerful but highly conditional tool.
This deep dive has shown us this incredible evolution in pharmacology, and it's all been driven by an increasing understanding of receptor chemistry. We began with the brutal, architecture-destroying, highly toxic barbiturates,
Defined by their ability to act as that chemical crowbar and bypass the natural inhibitory system entirely.
that gave way to the benzodiazepines, which revolutionized safety by moving to that frequency modulation model.
Offering a much higher therapeutic index and immense versatility, though, as we discussed, retaining that critical flaw of high dependence liability.
And finally, the modern era, where the goal is just ultra-specificity. We saw the Z drugs like zolpidem and zaloplam selectively targeting only the sleep components of the GABA receptor.
And the truly novel non-GABA mechanisms like ramelteon and suvorexant, which actively turn down the wakefulness signal itself.
The entire field has moved from just, knocking someone unconscious to chemically attempting to mimic natural sleep structure with physiological precision.
The drugs are getting smarter because our understanding of the sleep-wake cycle is becoming incredibly granular.
And that leads us to our final provocative thought for you, the listener. We are now targeting wakefulness, the orexin system, rather than just hammering on generalized depression with GABA. If we continue down this path, refining our pharmacological tools to match natural physiology, how much more precise can sleep manipulation become? Will we eventually reach a point where we can chemically induce a perfect night's rest, one that's indistinguishable from the real thing, where all the restorative stages are perfectly preserved and even optimized, maybe even improving cognitive function, all without any risk of dependence or rebound?
It's the ultimate challenge facing neuropharmacology right now. Creating sleep that is, in a word, chemically perfect, something to mull over before your next deep dive.